Dr. Shiva, you can start.
Please, sir. Please, I'll start, sir. Sir, I hope I'm audible, sir. Hello, sir. Sir, am I audible? Hello, sir. Am I audible, sir? Is this volume about enough, sir?
Sure, you're audible.
Jeez. Jeez, sir. Good evening, everybody. My name is Dr. Sivakumar, and I would be presenting tonight's IAN, and this would be a case presentation on a case of perinatal arterial ischemic stroke under the guidance of Dr. Saurabh Singh and Dr. Arjun Varma from Mahatma Gandhi Medical College, Jaipur. So the case, baby was a term female baby delivered in the Mahatma Gandhi Hospital, Jaipur, on the 15th March. And the antenatal history, mother is 26 years of life, and she's a G2P1L1, and the first child is a female child alive and healthy, 6 years of age, and she was booked in Jaipur with the normal antenatal scans and no significant antenatal events. Birth details: a term female baby was born via LSCS, indication being previous LSCS, and the birth weight was 2.77 kilos and gestational age 38 weeks. Baby had cried at birth, and there was no resuscitation that was required, and there is no sentinel events. We had received a call at around 2 hours of life from the postnatal care ward that baby had bluish discoloration of the skin following feeds, with regards of which we had rushed to the postnatal ward and we had started resuscitation over there. Baby had received bag and mask about 30 seconds. This was after birth at 2 hours of life. And with about 30 seconds of bag and mask ventilation, baby's heart rate had improved, and we had shifted the baby to NICU to evaluate. In the NICU, when we developed the baby was hemodynamically stable, heart rate was more than 100, and but baby had bradypnea, baby had apneic spells, and there was also peripheral cyanosis. We had ruled out hypothermia, and euthermia was established. We had taken the baby on non-invasive ventilation, and baby had required. We had started with peak inspiratory pressure of 16 centimeters of water and PEEP of 6 and FiO2 of 30%. And we had put the baby nil per oral and started the baby on the maintenance fluids and calcium gluconate. We had, in view of repeated apneic spells and desaturation as well as bradycardia, we had to take the baby on invasive ventilation, and we had taken the baby on volume guarantee mode with pressure support ventilation. And our initial X-ray was done, and there was no evidence of aspiration. This was done about 4 hours of life. We had also done an echo focusing on hemodynamics, and the hemodynamics were normal with normal biventricular function, and there was no significant pulmonary arterial hypertension. At about 8 to 10 hours of life, baby, as you can see in the video, had developed multifocal clonic convulsions, for which we had loaded the baby with 20 milligram per kilo phenobarbital. At this time, we had evaluated the baby for the various preliminary causes of convulsions. That would be hypoglycemia, but the RBS was 86 milligram per deciliter. And and at around 16 hours of life, baby had thrown second convulsion with similar seminology, for which we had to give the baby another 10 milligram per kilo of phenobarbital. By this time, we had gotten our labs, and the electrolytes were normal, serum calcium was normal, ionized calcium was normal as well, and the repeat RBS was normal. And baby was on 6th-hourly RBS monitoring regardless, which were normal. At 24 hours of life, 24 hours of life, we have a baby with unexplained apnea and cyanosis with no significant antenatal or perinatal events. And we had no obvious history of perinatal asphyxia. Baby was delivered in a hospital under our care. And baby had thrown two convulsions in the first 24 hours, multifocal clonic semenology. So at this point, the differentials that we were thinking were the first one would be hypoxic ischemic encephalopathy. Second, we had assumed it to be an hypoxic insult due to an aspiration, but then again, baby was only fed for the second time, and that seemed unlikely. And we had an X-ray the just to back it up. We had also thought of early onset neonatal sepsis, for which we had worked up sepsis profile was sent. Electrolyte imbalance was thought of hyponatremia, hypernatremic dehydration. But then again, this was only in 24 hours of life, and the baby was born in the hospital. And in less than 6 hours of life, the baby was in NICU care anyway. And the next thing we had thought of was syndromic causes or inborn errors of metabolism, as well as any structural brain malformations. And we had also kept a DD of neonatal stroke, either neonatal or perinatal ischemic stroke. But then we had ruled out the causes as such. So with we had done a cranial ultrasound bedside to evaluate the cause, and we found uh, this was done at 25 to 26 hours of life. And as you can see, and so we had started the scan in the coronal views. When at the C1 segment, the frontal lobes had appeared normal initially over here. But then again, as we had scanned to C2 and C3 and so on, we had found that there were hyperechogenicity found in the parietal lobe, and this echogenicity was found to be uh, to cover the most of the parietal lobe, and it fanned across, as you can see over here. And C4 and C5, so forth, you can see that the hyperechogenicity persists. And C5, and in by C6 we had reached the occipital lobe, and the occipital lobes are found to be unaffected. There was no hyperechogenicity found in this view. And when we had gone to sagittal view, they had found the hyperechogenicity was found on the left side. And in the sagittal views, you could see that there is also hyperechogenicity in the same in on the left side. And we kept scanning the C segments C3, C4, and you can see that the hyperechogenicity is still over here, even in the sagittal view. This is the left side, and we had not, and the occipital lobe is left relatively untouched. And when compared to the right side, the right the right-sided cerebral hemispheres were normal. There was no hyperechogenicities on that side. So with in view of these findings, with on ultrasound, we had found that there was hyperechogenicities on the right side with homogeneous distribution, predominantly involving the left parietal region, and we had found no intraventricular bleeds in well screening. At this point, we had ruled out intracerebral hemorrhage, and we had also ruled out early onset neonatal sepsis due to there being no obvious evidence of septicemia, either clinically or in labs, which will be shown later, as well as on examination. This was an LSCS in an institute, and it was a booked case in an elective LSCS procedure. So we are left with either with arterial ischemic stroke, and due to the echogenicity found on the left side on ultrasound in the parietal lobe, it could be due to left-sided middle cerebral artery territory infarct. It could also be hypoxic ischemic encephalopathy, as the finding that the baby had co- convulsions in the first 24 hours of life, and the mother, in spite of having clear-cut history, we couldn't rule out HI so far due to the cranial ultrasound findings, and syndromic causes as well as structural brain malformations. We still haven't ruled out. We have to send the reports. So these are the investigations. As you can see, the sepsis profile is relatively normal, and we had also done a lumbar puncture, assuming early onset sepsis, and CSF study was normal, and the electrolytes were also normal, as well as with the normal calcium. Ionized calcium was also more than 1 millimole per liter.
थोड़ा खाना खिला के नहला के पिला के पता रहा
We had gotten an continuous EEG
ना
study
भी दिला
done on after the first 24 hours of life, and the EEG
कैसे बच्चे
study could not record any
आवाज आ
seizure
रही है
activity. So we had proceeded with neuroimaging, and we had got an MRI brain. As you can see, there are some findings. This is the T2 weighted image of coronal view. You Hello, pardon, it appears I was muted. So these are the MRI brain images that were acquired on day of life 4, and as you can see, this is the T2 weighted image of the coronal view, and you can see that there is a loss of gray-white differentiation in the left cerebral hemisphere, and also there is bit effacement of the Sylvian fissure, as well as over here you can appreciate that the that in the T2 images. In the We had also gotten T2 flare images. You can see that the left-sided corticospinal tract appears to be hypointense, as well as it could be due to Valerian degeneration, as well as we had gotten diffusion weighted imaging. You can see that there is significant diffusion restriction in most of the parietal lobe, as well as the midbrain. And so the MRI report is as shown over here, and that reported that there is a large left middle cerebral artery territory infarct with almost all of the left MCA artery being involved, and the left lateral uh, ventricle effacement. There's also restricted diffusion in the corpus callosum, left cerebral peduncle, as well as in the pons and the medulla. We had also got an MR spectroscopy done, and over here we could see that there is suppressed N-acetyl aspartate and colon, as well as creatine peaks, and significantly raised lactate peak. You could see that there's marginally increased myoinositol peak. This would suggest that there were ischemic changes as well. And here is the angiography study, which shows a large MCA infarct, and you can see that the caliber of the vessel is irregular, and there's a flow void, and it shows that there's also an intraluminal flow void. So before we move on to the case, you can see that depending on the middle cerebral artery branch involved, the stroke manifests in different areas, with the main cerebral artery being involved, there is complete affection of the parietal lobe and also a bit of frontal lobe. And with anterior, you can see that the corresponding area is affected, as well as with the perforator branches. It involves only the deep gray matter, and with posterior cerebral artery, the branches, you can see that the affection is so. So we do not have this modality, but I also wanted to speak about neuroimaging techniques in MRI. The first one would be diffusion tensor imaging along with tractology. So diffusion tensor imaging measures the directional movement of water molecules along the white matter tracts. It uses a mathematical model, hence the name tensor, and the algorithm generates images that show the directionality of diffusion of water molecules as well as the magnitude. So you can see over here, this is the tractology image. So the corticospinal tracts, these are projected over the map, the anisometry map, that offers a 3D corticospinal tract reconstruction, and then they code it according to the anisotropic values. So this offers a better imaging perspective more than the conventional ones that are diffusion weighted imaging and T1, T2 weighted images, as well as flare. There is also arterial spin label perfusion weighted imaging. This is an MRI technique that uses blood water as a tracer in order to measure cerebral blood flow. It doesn't need contrast agents, so it uses radio frequency pulses to label arterial blood water as a tracer, and it allows the labeled blood to travel through the brain tissue. And so it gives information on regional perfusion. Here you can see there's a baby with birth asphyxia, and over here there's evidence of ischemic injury, and this was extrapolated to give perfusion weighted imaging. And there's a restricted blood flow in the bilateral thalamic area as well as the lentiform nuclei. So coming back to our case, in view of the MRI findings, we can positively speculate that there is a perinatal arterial ischemic stroke, and the points favoring would be we have a term baby with multiple episodes of apnea as well as convulsions, multifocal clonic type. There is also no history of perinatal asphyxia, and the baby had convulsions in the first day of life. And our bedside cranial ultrasound we could visualize that there was homogeneous echogenic foci in the left parietal lobe, as well as we could confirm our suspicions by getting MRI imaging. So moving on to neutral stroke, the definition, it's a group of heterogeneous conditions where there is either focal or generalized disruption of cerebral blood flow that is secondary to an arterial or cerebral venous thrombus or embolization occurring between first 20 weeks of fetal life through 28th day of life. And we need to have evidence by neuroimaging or neuropathologic studies. Classification of stroke goes, there's prenatal or fetal arterial ischemic stroke, that is due to the intrauterine events from 20 weeks of gestation to time of delivery. Next, we have neonatal stroke, that is throughout the neonatal period, we catch clinical phenomena such as seizures or mainly seizures, or in preterms, we see that the babies have persistent unexplained apneas as well as seizures, but most are apneas. We also have presumed perinatal stroke, where the clinical features may or may not be present in the first 28 days of life, but these babies present after the first month of life. And we also need to procure imaging evidence, consistent with stroke, as well as there is cerebral venous sinus thrombosis, and these strokes often follow infective etiology in the system. So, as far as our case is concerned, this is unlikely. This is definitely not a prenatal or fetal arterial ischemic stroke, as there is no outward antenatal history that we could recover, such as baby did not have any decreased daily fetal kick, as in the mother had not given us history of decreased daily fetal kick count, and as well as no smoking history, to say. And presumed perinatal stroke, it's not that, because we had the first seizure in the first day of life. We had positively ruled out cerebral venous thrombosis, as we had ruled out infective etiology, as well as mother had no history of fever, and there were no features of triple I, as well as we had done neuroimaging, where the venous system was relatively left untouched. The pathology was in the arterial system. So our diagnosis is most likely to be a neonatal arterial ischemic stroke. As far as etiology is concerned, when it comes to fetal etiologies, we could have any abnormalities related to the cord, and or chorioamnitis, or any chorionic villaitis, or fetal vasculopathy. But then again, in our history, there was no maternal fever, and placental complications were not there. We had spoken for obstetrician. In prepartum period, the mother was G2P1L1, and there was no smoking history, and the scan showed no evidence of any IUGR, and baby's birth weight was normal. That was 2.77 kilos. And also primary parity, the mother is G2P1L1. And the factors that would go towards stroke in neonatal etiologies were male baby, or low Apgar scores, or any hypoglycemic events, or early onset sepsis, meningitis, and congenital heart disease. We have ruled out all of these using labs and point of and focus. When it comes to an embolic versus thrombus etiology, in embolic strokes can be due to placental thrombosis, or in twin transfusion syndrome, it could be due to the other detritus or the vanishing twin, and it could be due to central vessel catheterization, but in our case, we had not inserted any umbilical lines, or any other any peripherally inserted central catheters or femoral lines as such. And we had ruled out congenital heart disease at focus, and our pediatric cardiologist was also roped in, who was able to confirm our findings. If you have to look at thrombus etiologies, then that would be due to any meningitis or septicemia and DIC, as well as trauma. But then there was no history of trauma. And fibromuscular dysplasia, we had no objective way of ruling out this condition at the moment, but this is not ruled out per se. And prothrombotic states, this could be a possibility for which we had worked up, as well as the other cause could be dehydration and or polycythemia. But we had admitted the baby on day one of life, and baby was on structured feeds and polycythemia. We had lab reports, and we had maintained adequate hydration of the baby. As far as prenatal stroke is concerned, they're mainly diagnosed due to fetal imaging, and most of them are due to vascular anomalies. Due to vascular maldevelopment that could lead to porencephalic changes and vasculopathies such as collagen vascular disorders or immune thrombocytopenia in the mother, as well as due to any vasospasm that could be due to any drugs such as cocaine or catecholamine surge due to an acute state in the mother, as well as vascular distortion. This could be the case when, due to any cause, if you have to intubate the baby, due to excessive neck rotation or excessive hyperextension, this could cause thrombi to form due to the Atlanta occipital joint being relatively lax. But this wasn't the case. And when it comes to the topography of the infarct, most of the cases are unilateral, and these cases mainly involve the left middle cerebral artery. This was so in our baby, and the basic pathogenesis of ischemic stroke, we would have to look at Virchow's triad, that is the hypocoagulable state where the concentrations of procoagulant and anticoagulant properties that are not very well balanced in neonatal age group, and even more so in prematurity and maturational stage of the brain as well. And also the cytokines act via NF-kappa beta pathway, and there is also the cause that the immature brain is more prone to apoptotic changes rather than necrotic changes that we usually see in adult stroke cases. Clinical features: focal seizure appearing in the first day of life, but more so after 12 hours of life is the hallmark. In preterm babies, they may be asymptomatic, and when we screen the babies for IVH, we may see uh, any hyperechogenicities or such in cerebral hemispheres. More than 50% of preterm babies stroke cases, they present as respiratory deficiencies or unexplained apneic spells. In term babies, they're mostly focal seizures, and in HIE, the convulsions tend to present in the first 12 hours of life, whereas in stroke, they appear in after 12 hours of life. So in our workup of our baby, we had spoken with our pediatric neurologist who had advised to work up for prothrombotic states. So we had thought of homocystinemia, and we had also sent protein C, protein S levels, and antithrombotic 3, and anti-phospholipid antibody levels, as well as we had suspected neonatal lupus. So we had sent an ANA profile. So our serum homocysteine levels were initially found to have been elevated a little bit above the upper limit of normal. And so as far as prothrombotic states go, it is recommended to get the definitive diagnosis when the prothrombic these factors levels reach the adult stages, that is after 3 to 6 months, as well as we need to evaluate these more seriously in case we have any positive findings, such as any strong family history, or if we find any additional thrombi, such as in the abdominal aorta or renal artery, for example. And we should also not forget to involve obstetricians to test the other mother for coagulation disorders. So protein C, protein S, and factor 5 lead in assay, as well as antithrombin 1 and 3, and homocysteine levels, and lupus anticoagulant and anti-beta to glycoprotein antibodies. We had not sent these, but we had sent homocysteine levels at our pediatric neurologist's recommendation. So we had also sent metabolic workup, that is gas chromatography, mass spectrometry, as well as here you can see that our GCMS report was normal, and our the ANA antinuclear antibodies report was also normal. There was no positive findings in this. As far as tandem mass spectrometry is concerned, most of the metabolites were reported as